This slideshow will cover all the information that's needed for Exam 4. It covers chapters 15 through 17 in our F.A. Davis book, and it's all about the newborn. So let's get started. So the focused care of nursing during the transition of this, from when it goes from a fetus to a newborn, includes the following different things. Our first main focus is to maintain respiratory and cardiac function on the newborn. If you're having a baby that can't breathe or its heart's not working correctly, the rest of the body isn't going to function either. So that's our main priority. But then other things we want to focus our care on would be maintaining body heat of our newborn, decreasing the risk for infection, assessing for any signs of complications, assisting parents in providing appropriate nutrition, whether that be breast milk or formula, and also educating our parents. These next few slides are going to talk about what happens as the newborn transitions to life outside of the uterus. So the first thing, the first physiological change that must occur after birth is that this newborn must establish respirations. So I included on here a little picture that shows you what the fetal blood circulation looks like in utero. And then once that baby is born and takes its first breath, there is a change. And what happens is the ductus arteriosus closes, and you'll see that that's up by the aorta up there, and then also the foramen ovale, or there's other ways to say that. That's just how I say it. That also closes. The closing of those two occur when baby takes its first breath. That breath changes the pressure within the vessels, and it helps close those two valves. Some things that can lead to respiratory issues include decreased surfactant levels. So surfactant is found in the lungs when you're the closer you get to your due date. So if the lungs are immature because they're preterm, they're not going to have enough surfactant levels. Other things that can cause the surfactant levels to be low include severe or persistent hypoxemia and acidosis. And what that will do is it fails for those pulmonary vessels to fully dilate, and therefore the foramen ovale and the ductus arteriosus don't close, and now you have unoxygenated blood flowing throughout the rest of the body. About 10% of the newborns, when they are born, require some sort of assistance with respirations. And that assistance can be just a little bit of some CPAP or PPV, and about 1% of newborns require extensive resuscitation. So it's not very common to actually have to do an extensive resuscitation on a baby, but you might have to just help them breathe a little bit. Once they breathe, we help them breathe, then everything else kind of starts functioning correctly. All right, so then the next system here would be our circulatory system. So again, talks about those shunts. Another picture before birth, how your oxygenated and unoxygenated blood flow, how it changes after birth. One other shunt that I want to mention, because it's on this one, is the ductus venosus. So you'll see that one is down lower. That connects the umbilical vein to the inferior vena cava, and that will close. The other two are the main ones that we get worried about because they're up by the heart. So the ductus arteriosus closes within about 15 hours of birth. But again, that can remain open or reopen even when the lungs fail to expand or that hypoxia occurs. And then the foramen ovale, that should close within about 24 to 48 hours after birth. The thermoregulatory system, when the infant is in utero, or not the infant, sorry, the fetus is in utero, it it's surrounded by amniotic fluid, and that amniotic fluid helps keep a constant temperature of that baby. Other things that can affect the fetal temperature is if mom's running a fever, then the baby can be a little bit warmer and everything like that. But really, that amniotic fluid helps keep a constant temperature. Now, once the baby is born, it's not surrounded by that amniotic fluid, and it needs to figure out how to maintain its own body temperature. Infants are at a higher risk of body temperature thermoregulatory problems because they have a higher body surface area to their body mass. They can have limited fat. They can have a higher metabolic rate, and they just might not be mature enough to be able to regulate their temperature, and they also have the inability to shiver. So it's really important that we try to keep it what's called an NTE, a neutral thermal environment. This is maintaining the body temperature with minimal oxygen consumption and a decreased metabolic rate. Infants can lose heat by a couple of different ways. We have evaporation, conduction, convection, and radiation. And the definitions for those are all listed in your book. The way that an infant responds to cold, so once it gets cold, it's going to increase its metabolic rate and O2 consumption. Okay, so it's going to start burning more calories to warm itself up. It's going to increase the muscle activity and go to a flexed positioning. It wants to pull its body closer to its core to kind of warm itself up. There's peripheral vascular constriction. So it can cut off some of that blood supply to the peripheral, like the arms and legs and everything like that, and constrict it. So that's where you might see some acrocyanosis occurring. And then it also starts breaking down or metabolizing brown fat. It can break down and metabolize it and warm their body up. Now, here's the thing though, preterm infants do not have a lot of brown fat. Therefore, their risk of becoming cold, it can occur very easily, and we must try to not let them lose heat by those 4 ways listed up there. Now, what do we do if an infant is cold? Well, let's say we have a term infant that comes out. What we want to do first is we want to dry off that baby. So we're going to wipe all the wetness off, remove any wet clothing or towels that it's laying on. And if everything is fine, you can place that baby skin to skin with mom, put a hat over it. It's kind of crazy and really neat that mom's body temperature can adjust to help keep that baby at the correct temperature. So if baby's cold, mom's body will warm up to help warm that baby up. Now let's say we do that, everything's fine, and we check a temperature. Remember, we do axillary. We check an axillary temperature and it's low. So our normal vital signs, our normal temperature for a baby is 36.5 to 37.2. Let's say it's 36.4. What are we going to want to do? Well, as long as everything else is going okay, we don't have any respiratory issues or anything like that, we can leave baby on mom's chest and maybe put some warm blankets over it, turn the temperature up in the room, try to warm it up that way. We're going to reassess in about 15-30 minutes. And if it's still cold at that time, then I would recommend bringing it over to the warmer and warming it up under there. It's going to need a little bit extra help to warm up. What can happen is if we let this baby stay cold for too long, it can develop what's called cold stress. This is excessive heat loss that results in compensatory mechanism to main body temperature. So now not only is our baby cold, but now its body is working so hard to increase the temperature that other things are affected. So what does that look like? Oops. So signs and symptoms of cold stress. Again, the temperature below 36.5. Their skin can be cool. They can be restless or crying. You'll see that acrocyanosis. Their breathing can be changed. So maybe they have tachypnea or they're grunting. They can have hypoglycemia. They can hypotonic or lethargic. They can be jittery. They can have a really weak suck if they're trying to eat. So what can happen, you'll see the consequences of cold stress. So their blood sugar can drop. Their oxygen can drop. They can go into metabolic acidosis. Their surfactant production is now going to decrease. And you remember from a few slides before, if we don't have enough surfactant, it's going to affect their breathing. So they can go into respiratory distress. This can also cause bilirubin to increase, which gives them jaundice. They have a weak suck and they have no energy left to eat, so they're going to be a poor feeder, which is going to lead to weight loss. At some point, they could just have no energy left. They could become apneic and lead to death. So what do we want to do? The first thing we want to do is try to limit this from actually occurring. So dry them immediately after birth. Remove those wet blankets. Put on a hat. Skin to skin. Put warm blankets over mom and baby. Pre-warm any instruments or anything that's going to touch your baby. So if you're going to put a stethoscope on your baby, you should warm it up first. Delay that bath. If your baby is having issues with maintaining their temperature, don't give them a bath. Wait until they're able to maintain a temperature on their own, because the bath is going to really drop their ability to regulate their temperature and stay warm enough. Swaddle them. And then again, keep monitoring and assessing their temperature. Some risk factors that a baby might develop cold stress include if they're preterm, SGA or small for gestational age. Think these babies aren't going to have a lot of fat to be able to warm them up or keep them warm. Other risk factors, if they're hypoglycemic. So think, we'll talk about hypoglycemia here shortly, but if their blood sugar is already low, okay, they're not going to have enough energy or metabolic metabolism to be able to burn calories to raise their temperature. Prolonged resuscitation efforts. Also, if they're septic, it can cause their temperature to go down and go into cold stress. So what you'll notice is that hypothermia, hypoglycemia, and respiratory issues, they kind of all go hand in hand. It's almost like once an infant develops one of them, they're going to develop the other two. And then it's hard to determine which one came first or which caused which. So you're really kind of having to treat the baby for all three things because they all happen. Okay, so our next system we're going to talk about here is the metabolic system. So really what we're worried about with this is hypoglycemia. Hypoglycemia is defined as a blood glucose below about 40 to 45 that first day of life. After that first day of life, it should go up a little bit more, about 50 or 60. But usually the hypoglycemia occurs during that first day. So some risks that your infant might develop hypoglycemia. If their mom has diabetes. Okay, let's talk about this. So when they're in utero and the mom has diabetes, mom's blood sugar is usually running a little bit higher. Well, that sugar is gets to the baby. So the baby is used to getting this higher sugar content. But the baby doesn't have diabetes. The baby can make insulin to cover that higher blood sugar level. But when the baby's born, it takes about a day for its body to realize, hey, I'm not getting that sugar from the blood from mom anymore, and I need to quit making insulin. But the baby continues to make insulin covering what they're used to getting for that sugar. Therefore, it drops their blood sugar. So we're not worried about a baby being born to a mom with diabetes. We're not worried that the baby's going to be diabetic and have high blood sugars at all. We're worried about its blood sugars tanking. Other risks to develop hypoglycemia: a really big baby or a really small baby, a preterm or postterm. Here comes that hypothermia. Okay, so if their blood sugar is low, if their temperature is low, they're using up all that energy to warm their temperature up, and now there's no sugar left in their body, therefore they're hypoglycemic. Infection can cause them to develop hypoglycemia. Respiratory distress, there's that second one. So now we have all three of them that can cause each other. Neonatal resuscitation or birth trauma. So what are some signs and symptoms that would make you think that your baby is hypoglycemic? You might see them be jittery or tremors. I'll show you what jitteriness looks like in class. They could be very irritable. They could have tachypnea or grunting. Again, there's our respiratory issues. They could have seizures. If their blood sugar gets too low, it could cause them to seize. Apnea, hypotonic, lethargy, hypothermia, cyanosis, and again, poor feeding. So what do we do if a baby has low blood sugar or if they have a risk to develop hypoglycemia? We should be checking their blood sugar within that first hour of life. If they have a lot of risks, we should be encouraging feeding as soon as possible. So whether that's if mom chooses to breastfeed or formula feed, we should do that ASAP to help get some sugar into that baby. If we check their blood sugar and it's low, okay, we're going to do a couple of things. It'll depend on where you work and what your protocol is, but if it's low, we're going to try and feed again. Sometimes you can do some oral glucose gel, and then you're going to recheck, reassess, right? And whenever you do an intervention, you want to reassess and see if it was successful or not. They might need an IV infusion of some like D10 or D5 of dextrose, or they might even need like an NG tube, okay, to help. If they have a really poor feeding and they're not taking anything in, how are you going to get that breast milk or formula in? You might need to put an NG tube in. And it's also really important to maintain their temperature because you don't want them to be cold. Again, it's going to be hard to get their blood sugar up if that's the case. This slide has some pictures of some newborns that were born to mom with uncontrolled diabetes. It could either be type 1, type 2, or gestational diabetes. These babies, as you can see, can have a lot of different things wrong with them. Well, first of all, their blood sugar is going to be low. They could go into respiratory distress. They're also at risk of hyperbilirubinemia, which is jaundice. They're at risk for congenital anomalies. So if you look on the pictures on the left, those are all some different congenital anomalies. Again, if their sugars get low enough, they can have a seizure, and they can be born very large. With that one on the right, I think that was, I don't know, a 14-pound baby, newborn or something like that. Even though that baby looks like it should be, you know, a full term and everything, should be good with it. These babies, when they're born, their lungs are really immature. So even though it's a big 13, 14-pound baby, its lungs are not developed. So it's going to have that respiratory distress. There's also extra weight, extra fat on their chest that when they breathe, they need to be able to move to inflate those lungs. So these babies, your big, fat, chubby babies, which I think are so cute when they come out, they need help breathing. And you'll see this baby here does have, looks like oxygen on. It has an OG tube in, looks like an IV, right? So lots of different things to try and not only help with its blood sugars, but help with its breathing. So another system we want to look at in our newborn is the immune system. Infections among neonates are some of the leading cause of morbidity and mortality that we see in newborns. Infants are born with an immature immune system, which increases their risk of an infection to develop during the first several months of life. So not only can it occur right after delivery, but really within those first few months after they're born. So what we want to do is we want to look at different risk factors that place an infant at risk for an infection. So there's maternal factors that increase their risk, there's newborn factors, and there's also environmental factors. So this is taken directly from your book, but let's look at some of the maternal factors. So poor prenatal nutrition, low socioeconomic status, substance abuse, history of a STI, recurrent abortions, lack of prenatal care, a prolonged rupture of membrane. So their water was broke for over 12 to 18 hours. They had group beta strep, GBS positive. Maybe the mom developed chorioamnionitis during labor. There was a maternal temperature during labor and delivery. Preterm labor, a difficult or prolonged labor, a UTI, invasive procedures during labor and delivery, like a scalp electrode. Maybe we used a fetal scalp electrode or an intrauterine pressure catheter. Also, if there was maternal tachycardia during labor. So those are all the maternal things. Neonatal factors that increase their risk for an infection, their birth weight. So if they're born small, premature, if they experienced birth asphyxia, meconium stained fluid, if they needed to be resuscitated after delivery. Maybe the infant was born with some sort of congenital anomaly. African American babies are at an increased risk, male babies, and also if it's twins, triplets, or multiples. Then we need to look at environmental factors. So if we have a prolonged hospital stay for the infant, that increases their risk of infection. The use of invasive procedures. So if we need to place an IV or do a lumbar puncture or anything like that. Use of humidified air, and also a routine use of broad spectrum antibiotics. So it can just cause, not to be effective anymore. So now that we looked at risk factors, what we want to do if we are assessing a baby or anything like that, we want to review or assess their history that increase their risk of developing an infection. And then we also want to start monitoring them for signs of infection. So infections can cause issues with a whole bunch of different systems in the newborn. So for example, respiratory, some signs of infection that is related to the respiratory system. You might see apnea spells, grunting, retractions, tachypnea, cyanosis. Those are all signs of a potential infection. Thermoregulation. So either a low temp or a high temp, or just really the inability to stabilize their temperature. Their cardiovascular can have issues, either a low heart rate or a high heart rate. You might start hearing arrhythmias. Their blood pressure might go up or go down. And then also their decreased perfusion. So maybe you see persistent acrocyanosis, decreased cap refill, potentially central cyanosis. Okay, neurological system that you might, or issues that you might see, tremors, lethargic. They might be irritable or have a high-pitched cry. Their tone is either going to be increased or decreased. They could develop seizures, have bulging fontanelles. For their GI system, they could be poor feeding, have vomiting, diarrhea. They might have an distended abdomen. Their liver or their spleen might become enlarged. If you're looking at their skin, they might develop a rash or pustules, pallor, jaundice, petechiae. And then for their metabolic system, you might notice glucose instability, metabolic acidosis. So what are we going to do? Okay, if they're at an increased risk, we're going to assess them a little bit more frequent than a baby with no risk factors. So frequent vitals, and by frequent, I mean every few hours. Usually it's every about 2 to 4, depending on your hospital policy. We're going to monitor their vital signs, monitor their weight, their I's and O's. Are they pooping? Are they peeing? Are they eating enough? We're going to handle our baby with standard precautions. Okay. If we suspect an infection, because an infection in a newborn can develop very rapidly and go to neonatal sepsis very quickly. Usually what we do is we work baby up and we start them on some broad spectrum antibiotics right away. So they might do blood cultures, they might do a CSF, a lumbar puncture to get some cerebral spinal fluid to test that. And just to kind of monitor and treat so that we don't wait for this to be worse than what it could be. So when you get called to go for the delivery of an infant, ideally you want to get there with a few minutes to spare so that you can review the prenatal record, also kind of the birth record or how the delivery is going, and you can identify any risk factors. So some risk factors that could affect how this baby is going to come out or transition to extrauterine life include if there was late prenatal care, limited care, or no prenatal care at all. If there's a history of maternal drug or alcohol use, if the maternal age is less than 16 years old or greater than 35 years old, if there's some sort of chronic maternal illness like hypertension or diabetes, any hypertensive disorders of pregnancy, so think of gestational hypertension, preeclampsia, HELP, any of those. If the baby is born preterm, so before 37 weeks, you want to look at different medications that were used in labor. For example, did mom just get fentanyl or some other narcotic, within the last hour or two? Is mom on magnesium sulfate? Some of your blood pressure lowering medications can affect the baby's blood sugar after it's born. So you really want to know what meds mom is on or recently took. And then you also want to know how long that water's been broke. Has it been a prolonged time? What color is the fluid? Is it clear or mix stained? Okay, so that was just kind of a quick little overview of the different systems. Now we're going to talk about what the newborn assessment consists of. Now you guys already did some of this in skills, so it's going to be kind of a quick little overview. But at the time of birth, so the immediate care, if you're the baby nurse and you're called in to come in for delivery, what are you going to do immediately after the baby's born? Well, we're going to do APGARs, right? At 1 in 5 minutes, we're going to assign APGARs. We're going to be monitoring baby's vital signs, and we're going to do a general survey. Now, the general survey is just kind of like, a glimpse, or you're going to just look at your baby, see if anything significant stands out to you. And if everything is fine, then you should be able to leave that baby on mom's chest for the golden hour, the first hour of life. After that time, once mom's ready to give baby up and everything like that, and you bring the baby over to the warmer, that's when you're going to do a full head to toe assessment. This should be done within about the first 2 hours of life, but this will include your measurements, a pain assessment, a gestational age assessment if needed, and also a full, head to toe look at your baby. It's really important to do a really good look and assessment of your baby and chart anything you see, because you're the first one to look at this baby, and it's up to you to be able to find anything, record it, let the doctor know if there's anything abnormal that you see. Then once the baby is born, you're going to assign an APGAR to it. So this is performed at 1 minute of age and 5 minutes of age. You look at the 5 different categories, so your activity, pulse, grimace, appearance, and respiration, and you score each category as 0 point, 1 point, or 2 points. You add up all your points, and a score of 0 to 3 indicates severe distress. This infant is not transitioning to extrauterine life. 4 to 6 indicates that there's some moderate difficulty, and 7 to 10 indicates minimal or no difficulty with adjusting to extrauterine life. So usually 7 through 10, these babies are okay. You can leave them on mom's chest. But 6 and less is when some additional interventions are going to need to be performed. This slide here you're going to want to review. I'm not going to go over it all with you, but it lists the normal vital signs and measurements for newborns. So this would be for a normal term baby when you're looking at the weight and length and everything like that. I do recommend looking at this and paying attention to the stuff that's in the parentheses. I also threw on here over on the right the targeted preductal O2 levels. So if you need to get a pulse oximetry on a newborn after it's born, you're going to want to put the pulse oximeter on the right hand. The reason that we say that is because the blood that's going to the right hand or right arm is preductal. So it's the blood that is in the going through the circulatory system before that ductus arteriosus opening from that is in the heart. Okay, so all that blood is going to the right-hand side before it would get mixed with any blood that's unoxygenated from the opening where that ductus arteriosus is. So you'll notice that initially at 1 minute of life, that pulse oximetry, a normal level for a newborn is 60 to 65%. But then each minute it slowly goes up. And once you get to 10 minutes of life, you should be closer to that 95% or greater. It's really important to know that these oxygen levels are considered normal for this time of age because we don't want to over-oxygenate our baby or do interventions that aren't necessary. So these next few slides are going over normal and abnormal findings when you're doing your assessment. So some normal findings related to respirations. They should be unlabored. You might notice diaphragmatic and abdominal breathing. Crackles initially may be heard for the first few hours after birth. That's okay. This is more common in our C-section babies or babies born very rapidly because that fluid doesn't get squeezed out of the lungs as it's going through the vaginal cavity of mom. So really what babies need to do if you hear crackles is they need to cry, and that will help kind of push out that extra fluid in their lungs. Babies might also have those apnea spells that last about 10 to 15 seconds. That's okay. And their breathing, it's just like an irregular, like we as adults, we kind of breathe like, every so many seconds. It's a regular pattern. Babies, it's normal for them to breathe irregularly. An abnormal finding related to respirations is if those apnea spells last longer than 15 to 20 seconds. Also, if they're breathing too fast or too slow, so over 60 or less than 30. For their pulse, when you're listening to it, you should listen to an apical pulse for a full minute. Murmurs might be present that first 24 hours. That's normal. It's fine because we're waiting for that ductus arteriosus. Remember, it just closed right after they took that first breath. We're kind of waiting for it to seal closed a little bit better. So sometimes it kind of, the little piece of, I like to say like a little piece of skin or tissue kind of flops around a little bit, lets a little bit of blood through it. That's what you're hearing the murmur for. Again, the normal pulse would be 110 to 160, just like a normal fetal heart rate. When they're crying, it might increase up to about 180. When they're sleeping, it can go down to 90. You'll also notice that like with activity or movement that can cause changes in their heart rate too. That's expected. Abnormal would be if their heart rate is higher than it should be or lower. Skin should be pink, warm. You might have some acrocyanosis, that's fine. Other things you might find on these babies is milia, lanugo. Babies that are 40 plus weeks, it's normal to have some peeling or cracking on their hands or feet, sometimes the rest of their skin. Hemangiomas, stork bites, newborn rash is all normal. Some abnormal findings would be central cyanosis after that first 10 minutes of life, jaundice before 24 hours, pallor, petechiae, a dimple, like a sacral dimple on the backside. When we're assessing their head, we should be looking for normal and abnormal findings. Some normal findings would be molding. This is just basically the head changing its shape to fit through the birth canal. So when you have a baby come out with like a cone-shaped head or it just doesn't look symmetrical, the body's made to do that initially. Their fontanelles and their suture lines, they're on a baby, it's not fused yet. So that occurs so that they can fit through the vaginal vault. Other normal findings is you want to feel the fontanelles. So you have the anterior and posterior fontanelle. They should be open yet, soft, intact. You might notice a little bit of a bulge when the baby is crying. That's okay. What you would get concerned about though is if the fontanelles are bulging as the baby's laying down. That could be a sign of, we'll talk about later, an intraventricular hemorrhage. The sutures might be overriding, so again, that's just to help it fit through the vaginal canal. Abnormal findings of the head, again, the firm bulging fontanelles, depressed fontanelles, so they're not flat, they're sunken. This could be a sign of dehydration. You also want to monitor for any bruising or lacerations. Bruising can occur due to a fast delivery, maybe the use of a vacuum or forceps. Lacerations could occur when they break mom's water. Sometimes they end up cutting it a little bit. So monitor for that. And then you also want to watch or look for caput and cephalahematomas. Okay. Caput is a buildup of fluid underneath the skin. It can be okay, but what we get worried about is if it's growing in size. Cephalohematoma is a buildup of blood a little bit deeper. It's not just under the skin, but it's under the sutures. So since caput is underneath the skin, it can cross the suture lines. Okay, so I put this little picture on here. A cap or caput covers the whole head, or it can, whereas cephalohematoma would not cross a suture line. So it's more of a one-sided bulge that you might notice. Since a cephalohematoma is a buildup of blood, we get worried that if it's growing, that they're bleeding inside. So their hemoglobin might be low. They might start basically hemorrhaging that way. So that's why we need to monitor it and keep a close eye on it. As long as it doesn't grow, caput and also cephalohematoma will reabsorb on their own. It can take a few days for it, but it does increase the baby's risk of jaundice. So we'd start monitoring for jaundice too. Then with the neck, as we're working our way down in our assessment, normal findings is they have a short neck with skin folds. They would have a positive tonic neck reflex. Abnormal findings of the neck would include webbing or large, thick skin folds, and then that absent tonic neck reflex. When we're assessing the eyes, they should appear equal and symmetrical. You might have a little bit of edema around them. That's okay. Their sclera should be white. However, you might have a subconjunctival hemorrhage. I threw a picture of that up on the left here. It's okay. It's just a blown blood vessel. It looks a little scary looking. Maybe show it to the parents so they're not like, oh my God, what's wrong? But it will get better. The pupils should react to light. Abnormal findings for the eyes would be unequal pupil reactions. When we're looking at the ears, the top of the pinna, so the top of the ear, should be aligned with the external canthus of the eye. If it's lower set, this is a sign of Down syndrome or other genetic disorders. The pinna should also be well formed without deformities. A full-term infant, if you pinch the pinna down to the lower cartilage of the ear and you let go, it should spring back up. Skin tags would be an abnormal finding on this. It's kind of crazy, but if you notice a skin tag on an ear, it can be associated with kidney issues because they develop at the same day in gestation. So as the ears are developing, so are the kidneys. So if something's wrong with one of them, there might be something wrong with the other one. Another thing that's abnormal is if there's an absent startle reflex. So, the startle reflex, so if you make like a loud noise, it should kind of startle or awaken the baby. If that doesn't happen, it could potentially mean that there's some deafness or hearing issues in the baby. When we're assessing the nose, a normal finding would be that it's flattened, maybe a little bit bruised. The nares should be patent. There might be a small amount of mucus that kind of comes out of the nostrils. Abnormal signs would be large amounts of mucus, a flat nasal bridge, so a flatter nose. This is seen in or associated with Down syndrome. Another abnormal finding would be nasal flaring. So as they're breathing, their nostrils flare out. Central cyanosis or cyanosis around the mouth is not a normal finding. That's a little bit concerning. As we move our way down to our mouth, it should be pink, moist, and intact. We should have a positive sucking reflex and a positive gag reflex. You might notice some Epstein pearls. These are little white balls, I guess, inside the mouth. It's okay. It's fine. They look like a pearl in a way. Abnormal findings for the mouth would be dry mucous membranes, natal teeth. So some babies are born with teeth. Also a cleft lip or a palate. So I threw a picture here of a little baby that's got a cleft lip. The palate would be the top part of the mouth when you put your finger in there. It should be closed. You shouldn't feel any openings in that. Moving our way down, looking at the chest, lungs, and cardiac. So a normal finding for the chest is that it's barrel-shaped and symmetrical. You might notice some breast engorgement. The lungs should sound clear. Again, you might have crackles for the first few hours. When you're listening to the heart, you should hear S1 and S2. Should have a regular rhythm. The murmur, if it is present, should disappear within 1 to 2 days. And if you're feeling for brachial and femoral pulses, they should be present and equal. Abnormal findings would be if you notice retractions when they're breathing. So you're looking at their chest, and every time they take a deep breath, the chest kind of sinks in a little bit. Maybe you see the rib cage or something like that. Persistent crackles that don't go away, grunting. So that's a noise that you hear when they breathe. It's like, prolonged periods of apnea is abnormal. Decreased breath sounds, especially if it's on one side, that could be a sign of a pneumothorax. Dextrocardia, and then also a murmur that doesn't go away within those the correct days. Looking at the abdomen, it should be soft, rounded, and symmetrical. Bowel sounds should be present. They might initially be hypoactive, but they should not be absent. The baby should pass their first stool, which is called meconium, within about 24 hours of birth. Also, when you're looking at their umbilicus, there should be no signs of infection of that umbilical cord. The cord should be clamped. That clamp gets removed about usually around 24 hours, maybe a little bit later of life, as long as it's drying correctly. Abnormal findings would be if we have asymmetrical abdomen, hernias present. Sometimes you might have like an umbilical hernia. If they're unable to pass a stool or an infected umbilical cord. For the rectum, the anus should be patent. And again, they should be able to poop within that 24 hours. Abnormal would be if it's imperforated, if there isn't anus at all, or you go and you look and you're assessing and there's no opening. Also, if you see any fissures or fistulas. Female genitalia, the labia majora should cover the labia minora and the clitoris. A little bit of edema is normal. Pseudomenstruation, so that's vaginal bleeding. It can occur due to hormones that the infant is receiving from the mom. Brick dust is what we call, you might see it in their urine. It's a really, if you took like a brick, like when you build a house, a brick, and you break some of it off, it's it's like a reddish, powdery. That's what the urine can look like, a brick dust. They should be able to void within the first 24 hours, and the urinary meatus should be midline. Male genitalia, the meatus should be at the tip of the penis. Their scrotum might be large, pendulous, and edematous. That's okay. Initially, it will go down. You should be able to palpate the descended testes. Again, they should void within 24 hours, and the brick test can be normal. When we're assessing the musculoskeletal and the neurological aspects of our newborn, normal findings would be that their arms and legs are symmetrical. They have 10 fingers and 10 toes, full range of motion on all four extremities. We would also look at their backside. They should have equal gluteal folds, no dimpling on their spine. So if you flip them over and you're looking at their lower part of their spine, like right above where the butt crack is, there should be no openings or dimples there. Their extremities, they should have a flexed position. They should have positive reflexes, so we'll go over reflexes in a few slides here, and they should have all of them. They should have symmetrical movements again, and their hands should be in a clenched position. That's normal findings. Abnormal would be polydactyly, syndactyly, so extra fingers, or their fingers are fused or anything like that. A simian crease, so if you're looking at their hands, they have one crease in the palm of their hand. Short fingers, wide space between their toes, these are all associated with Down syndrome. Hypotonia or hypertonia is an abnormal finding. Paralysis, if they're limp or floppy, and then asymmetrical movements. What are our reflexes? Here they are. We have the Moro, the tonic neck, rooting, sucking, palmar and plantar grasp, Babinski, and stepping and dancing. Know how to elicit all of these. They should all be present in our newborn. Okay, these next slides are walking us through our head-to-toe assessment. I'm going to be brief, but I did include on the slides for you to look through what some normal and abnormal findings are. So the first one is posture. You're just kind of looking at your baby and seeing what its posture is like. Is the extremities flexed? Is there symmetrical movements? Those are all normal. Asymmetrical would be a limp or floppy baby, which I showed you with the pictures here. A pain assessment. So we can't ask a baby, you know, like, are you in any pain? Because they're not going to tell us. So there's a couple different scales we can use to assess their pain. The one listed on here is the NIPS scale. This stands for Neonatal Infant Pain Scale. There's also a PIP. This would be a Premature Infant Pain Profile. So it's different things that you look at and you score them. And things that we can do to help decrease their pain, because we do a lot of painful things to babies, okay, especially if they're in the nursery or in the NICU or anything like that. We're poking them, we're putting IVs in, you know, putting an NG down. We might have to do a lumbar puncture. There's lots of things that we do to these babies. So we really should try to be doing some non-pharmacological pain relief if we can, and if needed, some pharmacological. So swaddling the babies can help. Non-nutritive sucking, so give them a pacifier to suck on, your finger to suck on. You can do some massage, or even just like rub their or stroke their face or their arm. Place them skin to skin, let them breastfeed. Do some sensory stimulation. Heel warmer, so before you poke their heel to get any blood, you should warm that heel up. Oral sucrose, so some sugar water can help with their pain. And then if needed for medications, some opioids or even some Tylenol can be given. Other medications that are given for our newborns. So we have the vitamin K, phytonadione. This is an IM shot, should be given within the first hour of birth. This prevents vitamin K deficiency bleeding, so it helps prevent them from hemorrhaging. It's very important that your babies, before we would do like a circumcision, to make sure that they've had their vitamin K shot. The next medication is the erythromycin eye ointment. This is a prophylactic treatment for gonorrhea or chlamydial eye infection. So this is just a little strip of the antibiotic ointment that goes in each eye. It will help decrease the risk of the baby getting any of those STIs within their eye from delivery. A hepatitis B vaccine is recommended to be given after birth to all babies. This is given IM. It's recommended again for all babies. They'll get follow-up doses as they age. And then the last one listed, the hepatitis B immune globulin vaccine. You may hear this referred to as HBIG, HBIG. This should be given if the mom is, if it's known that mom is Hep B positive, or if you don't know her hepatitis B status. So if that's the case, the baby would get the HBIG vaccine and also the hepatitis B vaccine. And these should be given within the first 12 hours of life. This will decrease the risk of that baby developing hepatitis B. Different tests that we do on our baby. So we have 5 different tests listed on here. The genetic disease screen, or you might have heard this referred to as the newborn screen or the PKU screen. This is a blood test that we get some blood from the heel. You fill these, it's usually 5 different little circles on a piece of paper, and you send it into the state. Each state tests for different things. But it's about 30 different disorders that it's looking for. It's looking for genetic diseases, metabolic disorders, even some infections. And this is done between 24 to 48 hours of life. And if it gets sent off, if anything comes back concerning, they'll get a hold of the parents for additional testing. Some states have you repeat this test in a few days of life. Some don't. The next one is a hearing screen. This one is done to check the hearing. If an infant does not pass, they can repeat it a few hours later. And if it doesn't pass that one, then they recommend going to see an audiologist to get additional hearing tests done. Hyperbilirubinemia screen. So this is a jaundice level. They check babies at about 24 hours of life. If your baby appears jaundice before then, you should check a bilirubin before then, as that is, we'll learn about here, a very severe form of bilirubin if it appears before that 24 hours. A CCHD, or a critical congenital heart defect screen. This is a pulse oximeter that you're going to put on the right hand, okay, our preductal right hand, and then you're also going to put one on one of the feet. Doesn't matter which one, okay? Both feet are postductal. So what you're doing with this is you're looking to see the oxygenation that's in your preductal, your right hand, and comparing it to your postductal down in your foot to see if they're about the same. We do this at 24 hours of life. They should be close, within 3 percentage points of each other, because that the ductus arteriosus and your foraminal valley should have been closed by this time. So if your baby fails this test, where it's more than 3 percentage points different, they need to get worked up for a heart defect to see if something's going on with that. And then the last thing listed on here is the car seat challenge test. You guys should have talked about this in peds, but it is a test that we do on our babies. We put them in a car seat and we monitor to see what their pulse does, their breathing, and their oxygen level. So think of a car seat when a baby's in a car seat and they're riding in a car. They are they're sitting up a little bit at a semi-recumbent, semi-Fowler's position. And sometimes what can happen is these babies, they don't have enough head control or head strength to keep their head up. So their head can fall forward, cutting off their breathing. So before we let the patient go home or discharge from the hospital, we have them do this car seat test. It's recommended that all preterm babies undergo a car seat challenge test before discharge. So all your preemies, sometimes they'll even do it on babies that are smaller or SGA. And if something, if they don't pass, they'll repeat it in about 24 hours. And if they still can't get them to pass, sometimes they will send them home on, it's called a car bed. So instead of having the baby sit up in a normal car seat, this type of car bed lays the baby down, and that's how they travel in the car. Okay, circumcision. So this is a hot topic these days. I feel like it's getting less and less common for parents to choose to circumcise their babies. But we're going to talk about different types of circumcision and the nurse's role. So there's a couple of different known benefits for circumcision. So there's a reduced risk of UTIs, reduced risk of HIV and STIs, and also, sorry if you hear my dog in the back. He's trying to get toys out of his toy box. There's a reduced risk of penile and prostate cancers in these babies. There are some contraindications, though not every infant can get circumcised. So if they're born preterm, if there's some genital urinary defects, bleeding problems, or any other compromising disorders. So for example, if they have hypoglycemia or respiratory distress syndrome, we're not going to circumcise them at that time. There are risks that go along with getting a circumcision. The infant could hemorrhage, could develop an infection, adhesions could form, and there's also pain that's associated with it. There are 3 different types of circumcisions that can be done. The Gomco and the Mogen are on the left side of this slide. A picture of both of them. The Mogen is the one kind of right in the middle with the white background. That one's not used much anymore. The Gomco, the one on the way left, is the common one used. Those two, both of them, they remove the foreskin. So when the circumcision is done, that foreskin has been removed, and you're left with kind of like an open sore or an open kind of like incision or so. Because of that, it can ooze a little bit and bleed a little bit. So what you want to place on it is some Vaseline and gauze. And you're going to keep that, that Vaseline and gauze on there. That will help with any bleeding or drainage or anything. The Vaseline will help keep it from adhering to the diaper. So you want to keep putting the Vaseline around the site until it's healed, which can take up to about 7 to 10 days. You want to educate the parents on how to take care of the site and also different things to monitor for, signs of infection or anything like that. The one on the right is the Plastibell. This is where a device, like a bell, gets placed on the penis, and it will slowly cause the skin to fall off. And about a week or so later, the bell will fall off with the extra foreskin. You do not need to put Vaseline or anything on this one because it's not an open sore. It just slowly kind of causes necrosis in a way of that foreskin to come off. That one I've seen used once in my 13 years of nursing, but you don't need to do anything for it. No Vaseline, no nothing, but still just monitor for any signs of infection at all. A bath. So you're going to want to educate your parents on how to give a bath. This is part of your clinical assignment, is to give a baby a bath. But some important things to do. First of all, when the whole time a newborn is at the hospital, the nurse should wear gloves every time you touch that baby until it's had its bath. Okay, so some babies don't have a bath while they're at the hospital. So that means every time you touch this baby, you should be wearing gloves. Okay, so there's a couple different ways you can give a baby a bath. You can do a sponge bath if you want. So just like think of it like a bed bath that we do for adults or the elderly people. You can do that, or you can do a swaddle immersion. That's what this picture is here. The baby is swaddled up in a blanket, placed in the water, submerged into the water, and given a bath. You can do, and you want to do this until the cord falls off before you do like a whole, I don't know, but you could do this, okay? Make sure that you do it in a room that's warm because this will drop your baby's temperature. So crank the heat up a little bit, keep them as warm as possible. You should try to do this quickly and efficiently, so finish within about 5 to 10 minutes. This will decrease the risk of hypothermia. Make sure to support the head and the neck at all times during the bath. Clean from the cleanest part down to the dirtiest. So start up at the head, the eyes, wipe from the inner canthus of the eye to the outer. Use a different part of the rag for the other eye. That will help decrease the risk of infection. Work your way down and then finish with the genitals. Other education that you want to provide your parents. Educate them on how to use a bulb syringe. Okay, never put the bulb syringe directly down the back of the throat, as that will initiate the gag reflex. So talk to them about that. Talk to them about sudden infant death syndrome, ways to reduce it. So you want your baby to not be around anyone who smokes, have them lay on their back to sleep, no extra pillows, bumpers, blankets in the crib. Talk to them about how to take care of the cord. So they don't need to do anything for the cord. They don't need to put alcohol or anything on it. It will just fall off on its own. You can tell them, though, to try to tuck the diaper underneath it and no clothes on it so it doesn't irritate it at all. Talk to them about what's normal for a baby to cry, or if they think that the baby has colic. So if they're thinking that, encourage them to keep a journal or a record of a day in the life of their baby. So every time it cries, write down, describe the cry, how long it cried, the time that it ate, when it pooped, when it slept, so that they can start kind of have a record, and to see if there's certain things like, is this baby crying for 2 hours after a feeding? If so, maybe the baby's not liking the formula. Or is it crying before a feeding and then once you feed it, it's okay? Well, if so, it sounds like it was crying because it was hungry. Talk to them about a diaper rash and what to do for it. Don't use baby powder on a diaper rash. They can use some like zinc oxide or something like that, but they should never use baby powder. They should have a follow-up appointment with their pediatrician within 2 to 3 days after discharge. Talk to them about signs of jaundice and what they should do for it. So if they feel like their baby's getting really yellow, maybe not waking up for feedings or crying, very high-pitched cry, could be signs of high jaundice levels. So they should come in for that. Safe sleep we talked about. Other safety, like with siblings around, as this baby grows older, baby-proofing their home. Talk to them about bathing. Car seat safety. So the car seat, the best spot for the car seat is in the back seat. If they have a car, like an actual car, the back middle is the best spot for it. It should be rear facing. And then teach them how to swaddle. So swaddling with their arms in, you want it snug. You should be able to fit 2 fingers in between the blanket and their chest. And you want to make sure that it's a tight swaddle, not a loose one where they can get out of it. You can keep swaddling them up until they can roll over. And at that time you want to quit swaddling. Otherwise, it can increase their risk of SIDS or suffocating. Okay, let's talk about Chapter 16, Newborn Nutrition. So we're going to talk about breastfeeding and formula feeding. So there's a couple of different benefits that we're going to talk about here with breastfeeding for the infants and the mother. So the mom benefits is there's a decreased blood loss after having a baby, because when you nurse, you release oxytocin, which clamps your uterus down, helps with your blood loss. There's a decreased risk of infection, increased weight loss because you're burning a lot of calories when you breastfeed. There's a decreased risk of diabetes later on in life, decreased risk of osteoporosis, and decreased risk of some different cancers like ovarian and breast cancers. So there's a lot of benefits for breastfeeding for the mom. For the infant, their benefits include a decreased risk of gastroenteritis, RSV, ear infection, necrotizing enterocolitis, SIDS, and decreased risk of obesity. With breastfeeding, there are some women who it's contraindicated for them to breastfeed. If the mom has active and untreated tuberculosis, she should not breastfeed. If she has an active herpes lesion on her breast itself, that baby should not breastfeed. If mom is HIV positive, HIV is passed through the breast milk, so she should not breastfeed. If she's on certain medications like chemotherapy, an anti-metabolite, those are all contraindicated for breastfeeding. If she's using illicit drugs such as amphetamines, PCB, cannabis, or cocaine. They do recommend, however, if she's on methadone, so a controlled drug, that it is okay to breastfeed with that, because a little bit of that will be passed through the breast milk to the baby to help it withdraw a little bit easier. If mom's receiving radiation, that's another reason not to. And then if the newborn, if the screening, that genetic screening that we do, that we get some blood and send it to the state, if it comes back and the newborn is diagnosed with galactosemia, then this newborn needs to be on a special diet, special formula, and should not be breastfed. Babies will elicit some feeding cues or hunger cues. For example, they'll start licking around, smacking their lips, sticking their tongue out, maybe putting their hand in their mouth or sucking on their fingers, rooting. They could also have this quiet alert stage where they're awake and looking around. Those are all the early signs of hunger or feeding cues, and that's when you want to feed your baby. A late sign is crying. Okay, crying usually doesn't happen when they're hungry until about 30 minutes after they've started showing these other feeding cues. So you want to feed the baby before you get to that crying or that late sign. When a mom is nursing, we can do what's called a latch score to see how good of a breastfeeding experience that time it is. So we look at LATCH, so it stands for the actual latch. Is there a latch or not? Is there audible swallowing that you hear? You look at the type of nipple that mom has, the comfort or how comfortable she is, if there's pain with it, and also the hold. So is mom able to hold baby herself, or does she need a lot of assistance? And that's out of 10 points. So you just kind of, if you're at the hospital working, you should assess at least one feeding a shift and do a latch score to see how it's going. And then you also want to look at to make sure your baby is having adequate intake and output. One of the things with breastfeeding is that you don't know how much your baby is actually getting. And a lot of parents, this is one of the reasons that they are scared or elect not to breastfeed, because they don't know if their baby's getting enough. So you should monitor their I's and O's, making sure that they're pooping and peeing. So the first week of life, a good way to make sure that they're having enough voids is every day of age that they are. So if they're 1 day old, they should have 1 void. 2 days old, they should have 2. 3 is 3, all the way up till they get to 7 days. Once you get to 7 days, then they should have about, so on day 8, they should have 8 wets every day and kind of stay that way. Poops. Poops, on the other hand, it doesn't go 1 per day like you do for breastfeeding, or sorry, for voiding. But you do want to monitor their poops, and I believe I have a slide on that coming up here, but making sure that they are having stools too. Okay. So formula feeding, some advantages to formula feeding for the moms who choose to do this. They can include others to feed. Okay, so you know, the dad or their significant other. Mom is able to leave infant. She can go do something. The infant isn't attached to her 24/7. There's actually decreased number of feedings per day because formula takes longer for the body to break down, so the infant stays fuller longer. Some disadvantages is there's a cost to it. You have to take time to prepare the formula, wash the bottles and everything like that. There's also an increased risk of infection to the newborns due to the lack of antibiotics that are present in breast milk. Increased risk of illness, obesity, and insulin-dependent diabetes. You'll want to educate the patients on how to prepare the formula. So those directions should be right on the formula can, and they should follow those. And you also want to make sure that they know how to bottle feed. So for example, they shouldn't prop the bottle. They should hold the infant close to them when they're feeding and hold the infant so that its head is higher than the bottle. Here we go. Here's that normal output and different pictures of what the stool will look like. So look at this graph, or not this graph? Sure, that I put on here that talks about how many poops and pees they should have and what it should look like. Okay, chapter 17, complications of the neonate in nursing care. Okay, so we're going to start off by talking about a preterm infant. So an infant born before 37 weeks. The earlier that you have a baby, the more risk factors that it has, or more complications that it is susceptible to. So first of all, let's think of some different risk factors of why you might deliver preterm. If you have a history of delivering preterm with another one, if you're pregnant with twins, triplets, quadruplets, anything like that, if there's a uterine abnormality, different race has an increased risk of delivering early. Pregnancy-induced hypertension, a short interval between your pregnancies. So let's say you had a baby in January, you got pregnant again, and now you're due in November. Your water broke early, bleeding in the 2nd or 3rd trimester. You're less than 17 years old or greater than 35. If it's an unplanned pregnancy, you have a low socioeconomic status or low educational level, intimate partner violence, stress. If you got pregnant off of IVF, if you had a low pre-pregnancy weight, or you were obese, hypertension, diabetes, anemia, substance abuse, smoking, later no prenatal care. So there's lots of different things that put you at risk for developing early. Some common assessment findings that you will see in preemie babies is they're going to have respiratory distress syndrome, hypothermia, hypoglycemia. Again, those 3 going together. They're at risk for infection, jaundice, skin breakdown. Because of that skin breakdown, you want to make sure that you're repositioning your infant at least every 4 hours and using tape very sparingly. If you can figure out how to not use tape on your baby, like if you need to tape the IV down or tape an NG tube or anything like that, they make special things that won't cause skin breakdown, because when you take on a 24, 25 weeker, their skin is so translucent, so frail. If you were to peel tape off, you could peel the skin off. You'll see in this picture here, this is a preemie baby, and it's in like a Ziploc bag. I like showing this because people think I'm crazy with the Ziploc bag, but this is a way to help this baby maintain its body heat. So that's something that you'll see with severely preemie babies. Okay, a gestational age assessment. So this is something that can be done on babies who, used for patients who come in and they deliver. We have no prenatal care, so we don't know how many weeks gestation they are. If they're born premature or post-mature, post-states, we can do this. If their weight is less than 2,500 grams or greater than 4,000, if their moms are diabetic, or they're admitted to the NICU. So basically what this does is it helps us determine how many weeks of gestation they truly are. Just because a baby grows and is born a 10-pound baby doesn't mean that it's, a 40-week-old baby. It could be a, 33-week-old diabetic baby or baby born to a mom with diabetes. So it looks at different physical and neuromuscular characteristics that develop at a certain gestational age. So you'll see I listed them on here, the different neuromuscular maturity, so like their posture, the scarf sign, heel to ear, all different things. And then the physical maturity, we have the skin, the lanugo, the plantar surfaces, breast, eyelids, and the genitals. So you score your baby on each of these, and then you add up your score, and you'll see down at the bottom right that the scores are related to different weeks of gestation. The reason that we want to know this is because it doesn't really matter the size of our baby, but it matters how many weeks they are of gestation, that they truly are, because there's different things that they should be able to do at certain weeks. For example, the whole suck, swallow, breathe. So in order for a baby to know how to suck on a nipple, swallow the food, and breathe, that doesn't develop, that's something that develops closer to their due date, so more like 34 to 36 weeks. Okay, so if you have a baby that is having issues with the whole suck, swallow, breathe, and you think, oh my gosh, but you're a 9-pound baby, you're 39 weeks. Maybe they're really not. Okay, so maybe if we do our gestational age assessment, we'll see that no, this baby's really only 33 weeks, and this is normal that they don't know how to do the suck, swallow, breathe. But if you do the gestational assessment and you find that no, they are 39 weeks, but they still don't know how to suck, swallow, breathe, why do they not know that? So this is also called the New Ballard score, and we worked on this in Skills Lab. Okay, respiratory distress syndrome. So respiratory distress syndrome, some common assessment findings you'll see is tachypnea and tachycardia. You'll see retractions, seesaw breathing, grunting, flaring. They're going to have increased oxygen demands. So I have listed on here your normal PaO2 and PaCO2 listed on there. They could have central cyanosis, decreased lung sounds or apnea, and they can become lethargic and hypotonic. So what can happen with respiratory distress syndrome? Like, why do we worry about it? And why do we want to do something about it? Well, if you leave a baby in respiratory distress syndrome for too long, it can cause a whole bunch of different things to occur, like a PDA. They can develop a pneumothorax, bronchopulmonary dysplasia, pulmonary edema, hypotension, anemia, oliguria, hypoglycemia, retinopathy of prematurity, seizures, and intraventricular hemorrhage. There's a lot of bad things that can occur because of respiratory distress. So what's the treatment for this, or what do we do if our baby is having some respiratory distress? Well, we need to try to help this baby breathe. So this might mean that we're going to put on a CPAP. Okay, so your baby's breathing, but it's just not getting the alveoli to open up correctly in the lungs or something like that. So we can put a CPAP, a continuous air being forced into their lungs. You can put that on them, and that will help expand and open up the alveoli and keep them from collapsing. Another thing that can be done is we know that RDS can be due to low levels of surfactant. So we can actually do surfactant replacement therapy. So this gets administered via an ET tube. So they'll put an ET tube in and they aerosolize the surfactants right directly into the lungs to help increase that amount of surfactant in there. Okay, our next complication which can occur is called bronchopulmonary dysplasia, or BPD. So this is common for our babies that have been on a vent for a very long time. So what you'll see with BPD, things that make you think that your baby has this. You're going to see chest retractions, wheezing, rales, rhonchi, hypoxic, respiratory acidosis, bronchospasms, difficulty weaning from the vent, intolerance to fluids, and you're going to want to do a chest x-ray. So this occurs after the baby has been on a vent or on oxygen for 28 days of life or longer. So it's not something you'll see initially, but if we need to leave a baby with that extra oxygen or anything like that, this could develop. So as we try to take them off that oxygen or the vent, their lungs are so, they get so firm and they can't expand or everything on their own. So we try to take them off the vent, but now their lungs don't want to work. So now we got to put them back on the vent to breathe for them, which makes a bronchopulmonary dysplasia worse. So it's a fine line, just causing damage to their airway and the vascular damage. So we try to hopefully not leave them on a vent or with oxygen for a prolonged amount of time so that we don't have them develop this. Okay, a PDA, a patent ductus arteriosus. This should be a review from PEDS. So here, if you look at this picture, it shows you where the ductus arteriosus is. It's right coming off of the aorta into one of the pulmonary veins. That should close, but if it stays open, it is now a patent ductus arteriosus. So you would think that your patient has this. If you hear a murmur that persists longer than that 24 hours, an active precordium, bounding pulses, tachycardia, tachypnea, recurrent apnea spells, an increased work of breathing, and an increased oxygen demand or ventilation. If you think that the baby has this, they're going to do an echocardiogram to diagnose it. You're going to want to restrict the fluid of your babies. They might give some medications like diuretics and indomethacin or ibuprofen, as those can help close that PDA, and they might need surgery. So this is something that that with a murmur, that this is something that they kind of suspect might be going on. Okay, the next one is an intraventricular hemorrhage. This most oftenly occurs in premature, very low birth weight infants, so our very little babies. And most likely it's going to occur in the first week of life. So this is where there's a brain bleed, something within the ventricle. Now, think back to when we talked about preterm labor before, and we had said that sometimes moms go on magnesium sulfate to help decrease the risk of a brain bleed in our babies. This is what we're trying to decrease the risk of. So in our moms who are in preterm labor, if we think that they are going to deliver, and these are like before 30 weekers or so, They might put them on magnesium sulfate to decrease the risk of this. But things that would make you think that your newborn is experiencing an intraventricular hemorrhage include a sudden deterioration in their condition. So maybe, that's like a change in their LOC or their vital signs. It's a sudden change in them. O2 desaturation, they're bradycardic and hypotonic. Metabolic acidosis, they can go into shock. They can have a significant decrease in their hematocrit because they're bleeding out inside their brain. All that blood is going within that ventricle. A full or tense fontanelle. So this is where you'll see that bulging fontanelle. And then hyperglycemia. If you think your baby is experiencing this, you need to report this to your provider right away. What they're going to do is they are going to come do a lumbar puncture, and that's what this picture is. Okay, they're taking some fluid out from in the spinal cord area to see if there's blood or anything like that. You can do a CBC because we're going to look at its hemoglobin and hematocrit. You might need to do a blood transfusion on these babies to replace that blood that's being lost. You're going to do a head ultrasound and look for the hemorrhage. You really want to reduce any stress that you can. Okay, so a quiet, dark environment. You want to keep their head straight. If you do need to give fluids back, fluid replacement, you're going to do it slowly because if you do it too fast, that's going to increase the amount of fluid in their vessels, which can make more blood bleed out. Our next thing here is necrotizing enterocolitis, or NEC. This is an inflammation and necrosis of the bowel. This mostly occurs in our preemie infants or infants that had a prolonged rupture of membrane with an infection. Also, if they've experienced birth asphyxia, are small for gestational age babies, congenital heart disease, anemic, or formula feeding. Okay. This is why in NICU babies, they really highly encourage not to formula feed your baby. Breast milk is the best for these babies to decrease their risk of NEC. These babies, what you'll find upon assessment, basically that part of their bowel no longer works. Okay, so that bowel, that stool is just accumulating in their bowel. So you're going to notice abdominal distension. It could be tender to their belly. They could be vomiting. They're going to become lethargic. They might have apnea spells. You might notice some blood in their stool, temp instability, hypotension, shock, decreased output. If you think that your baby is developing NEC, you want to place some NPO. So quit giving them anything into their belly because there's nowhere for it to go. Gastric decompression, so an OG or NG tube to help decompress any air or anything like that in their belly. IV fluids to keep them hydrated, and they're going to need surgery. What they do with surgery is they take out that dead part of the bowel. This is fatal in 20 to 30% of cases, especially if it ruptures or if it can be so bad where they have to remove all of the bowel. Retinopathy of prematurity. This occurs commonly in preterm and low birth weight infants. It's due to giving too much oxygen or a prolonged amount of oxygen to our infants. The retina, it's not completely vascularized, so it's very susceptible to stress or injury. So when we give extra oxygenation to these infants, it can cause abnormal blood vessel growth, and you'll see that over on the right side there. So with these babies, it's common in ones with prolonged hyperoxia, so extra oxygen that we have to give them if they have a PDA and also an intraventricular hemorrhage. So we need to be very careful with how much oxygen we're giving babies. We want to give them the least amount that is needed to keep their oxygen level where it's supposed to be. We also want to use an oxygen blender. So what that means is you're not given full force 100% oxygen. You want to blend it with some air to get it to the right percentage that you want it. We're going to do continuous oxygen monitoring. Because with the retinopathy of prematurity, long-term outcomes include glaucoma, cataracts, blindness, the use of glasses. So lots of different things that can happen with too much oxygen. Meconium aspiration syndrome. So we've talked about meconium stained fluid during labor. What we get worried about is if that infant actually aspirates some of it into its lungs. So what this can cause is that thick meconium fluid in the lungs can cause an obstruction of the upper airways. In the lower airways, it causes air trapping and hyperinflation of the alveoli. So if you know that there's meconium stained fluid when you go for the delivery, you should kind of know what color fluid it is. What you want to do is you want to suction the mouth out with a bulb syringe. Remember, we do mouth first and then nose. If there is thick meconium present and the baby is having some issues with breathing, you can do an endotracheal suctioning to get that thick mech out from the trachea. Respiratory distress syndrome is common in these babies. And you also want to monitor their blood glucose with this mech aspiration syndrome. Persistent pulmonary hypertension of the newborn. This is where the blood pressure in the lungs stays higher and it should be lower. So think of blood, it's going to flow from a higher pressure to a lower pressure. Okay, so if we have the pulmonary hypertension, so a blood pressure higher in the lungs than in the heart, we're going to have a backflow. So our blood won't flow from our heart to our lungs. It's going to go from our lungs to our heart. So it's going to backflow. And not go the correct way. So some risk factors to develop persistent pulmonary hypertension include hypoxia and asphyxia, a low APGAR score, if they're septic, meconium aspiration or RDS, and hypothermia. So what you're going to find with these infants is they're difficult to vent. They could have tachypnea, cyanosis, their blood pressure is going to be low. You might hear a heart murmur, hypocalcemia and hypoglycemia, and they can go into DIC. So what we want to do for these babies is we want to correct that hypoxia and acidosis. We're going to try to mechanically ventilate them, give them IV fluids, give them surfactant to get their lungs better. Nitrous oxide, that will reduce the pulmonary resistance. And then we can also give other medications like vasopressors, vasodilators, some paralyzing agents, especially if we have to vent them or put them on a vent, and then some antibiotics. Hyperbilirubinemia or jaundice. We get worried about this because what can happen with high levels of hyperbilirubinemia is the infant can develop acute bilirubin encephalopathy and kernicterus. This is permanent brain damage. So we have two different types of hyperbilirubinemia, or two different types of jaundice is another word. The first one is physiological. This one is, think of when you think physiologically, like that's a normal expected process. This occurs after the first 24 hours of life, and it can last up to about a week, usually peaks on about day 3 of life. This is caused by breakdowns of the red blood cells, and it progresses from the head down towards the trunk. It's usually not enough to be severe enough to develop a whole lot of treatment. The one that we get worried about is called the pathological. This one occurs within the first 24 hours of life and can last longer than 2 weeks. You'll also see with this a rapid increase in their bilirubin levels. So pathological jaundice can be due to blood incompatibilities. So either the Rh factor, so either mom's an Rh negative and baby's a positive, or even an ABO incompatibility. So where mom's blood type is maybe, I don't know, O and baby is A. Okay, it's not the same thing, it's incompatible. It can be due to polycythemia, so a whole bunch of red blood cells. It can be due to metabolic and endocrine disorders, a GI obstruction, or an infection. Risk factors that a patient might develop hyperbilirubinemia. There's certain ethnicities, so American Indian, East Asian, or a Mediterranean descent are at a higher risk of getting this. Breastfeeding babies, if moms have diabetes, if oxytocin was used during labor, delayed cord clamping, delayed feeding, bruising, and prematurity. They can all cause this hyperbilirubinemia to form. So things that we want to do to test to see what level our babies are at, we can do a TCB or a TSB. TCB is transcutaneous bilirubin. So we just put that little machine on their skin. It tells us a number. Or a TSB is transserum bilirubin. This is the actual amount of bilirubin within their blood. Other blood tests that we can do is a Coombs test. This is used to determine if there's hemolytic disease of the newborn. So if it's related to an Rh or ABO incompatibility, they would be Coombs positive. Then we would know that they have that pathological type of jaundice. We can also do a CBC. This will detect if there's any anemia, which would indicate that there's hemolysis or infection going on. What we're going to do if it comes back that they are jaundice is phototherapy. There's a couple different types of phototherapy, but basically what it is it's a light that gets placed on top of baby, and it converts bilirubin to a water-soluble component so it can be excreted in the poop and pee. So if you need to start phototherapy on your infant, a couple of things. One, they should be stripped down just to a diaper. Okay, so you just want their genitals covered, and they should have an eye patch over their eyes. So whenever they're under the light, they should have this eye patch on. Otherwise, it can cause eye damage. You want to keep them under the lights as much as possible. The lights should be placed 12 to 16 inches from the newborn. So you take a measuring tape, measure from the newborn's, belly up to the top of to the light, and it should be 12 to 16 inches. You want to change the position frequently for a couple of reasons. One, you don't want to cause skin breakdown, and two, you want to make sure that you're exposing different parts of the skin for that breakdown of that bilirubin. Monitor your eyes and nose. Monitor your vital signs to make sure your baby's not too cold or too hot. And then take your babies out for feedings. You want to feed every 2 to 3 hours. And remove those eye patches when it's not underneath the lights. Neonatal abstinence syndrome. So this occurs when the newborn was exposed to substances in utero. This slide lists a whole bunch of different things that would make you think that possibly your baby is going through NAS. So apnea spells, diarrhea or loose stools, excessive crying, excoriated skin, fever, or high-pitched cry. There's lots of different things listed on here. I encourage you to look it over. This video we will watch in class. But it shows a baby going through neonatal abstinence. What are you going to do if you think your baby's going through neonatal abstinence? Is something called the Finnegan score, and I have that on the next slide. I'll show it to you. But you're going to score your baby in different areas, and you want to make sure that you report scores that are increasing, because this increasing scores, especially 13 or greater, means severe withdrawal. And if your baby is going through severe withdrawal, what can happen? Think of a normal human being when you're going through withdrawal. It could cause you to become ultimately die because you're going through that withdrawal. So before that were to occur for a newborn, we would give it some medications, usually some morphine or something like that, a small amount, and then each day we would decrease how much medications were given it to make that withdrawal not so severe or so intense. You're also going to do daily weights on your babies, skin care, just because they're at an increased risk of skin breakdown with this. Frequent small feedings. Here's that breastfeeding again. No breastfeeding unless it's methadone that the mom is on. You want to have a gentle, soothing environment. So a lot of times these babies are in their own little room in the nursery, lights down, to try and keep it as quiet and calm as possible. And also educate the parents. This slide shows you what that Finnegan score looks at. So you score your baby in all these different categories. Last little thing we're going to talk about here is some congenital abnormalities. So these are the leading cause of infant fatality. It's a result of chromosomal abnormalities or some environmental factors. So like teratogens, like think of our torch infections that we learned about in exam 1, different medications, alcohol, illicit substances. Hopefully if the mom was positive or exposed to any of these teratogens during her pregnancy, hopefully ultrasounds were done to follow up on it to see if there was any congenital abnormalities. Table 17-7 lists some common ones. The one that I do want to touch base on is Down syndrome. So some common findings, physical findings in a baby that would make you think that maybe this baby has Down syndrome. A protruding tongue. So sometimes their tongue is so big that it's kind of like always sticks out of their mouth. They can have that simian palmar crease, so that one transverse crease in their hand. Muscular hypotonicity, so they're very flexible, like no tone at all or anything like that. Low set ears and a flat nasal bridge. Other things that you could see is if you're looking at their toes, there's a wide separation between the big toe and the second toe. Those are all some common signs. All right, that ends our exam for recorded PowerPoint for you.